All right, so I have no disclosures. Okay, so we're going to discuss now, and we're going from treatment now to prevention, but I think the talk of Dr. Lacaretti was very helpful on letting us see how, before we get to atrial fibrillation, we want to prevent it if we could, and once the patient develops atrial fibrillation, we want to also implement secondary prevention strategies, because as you're going to see with this data, after ablation, you may be able to prevent the recurrence of atrial fibrillation if you can institute on time effective lifestyle modifications that reduce the risk factors. So the objectives are to discuss the rationale for an atrial fibrillation prevention strategy, which we kind of did already. We're going to identify modifiable risk factors and understand the evidence supporting the lifestyle changes for prevention of AFib. So just a quick question for the audience. I mean, it's very simple. Do you manage atrial fibrillation every day, once a week, once a month? You don't treat atrial fibrillation, or maybe you yourself have been diagnosed with atrial fibrillation? So that I just
those aren't mutually exclusive.
Well, yes, some of are mutually exclusive, but choose the one that best characterizes your situation, or the one that you prioritize as your answer. All right, very good. So, most of you are seeing atrial fibrillation every day, so I don't have to tell you atrial fibrillation is very common. Good news for the audience as well as for us is that we have job security. The projected prevalence of atrial fibrillation is only going to go higher. Millions of patients by 2030 is almost a duplication. And even if you assume that the incidence of atrial fibrillation is not logarithmic, which it is, by most estimates, we're going to be seeing a lot of atrial fibrillation in the coming years. Atrial fibrillation, as we saw already, is associated with morbid mortality, a higher incidence of strokes, a proven causality of strokes, I think, with the most recent clinical trials data, and with the data from left atrial appendage exclusion, increased risk of dementia, myocardial infarction, heart failure, and mortality. Atrial fibrillation is very expensive. There are a lot of readmissions. It is expensive drugs, expensive treatments. So the calculation is by 2005, between direct and indirect costs of managing and caring for patients with atrial fibrillation, it was up to $26 million in the US just for that year. We saw that, we know that there is no single cause for atrial fibrillation. It's a multifactorial disease, and despite all the advances with catheter ablation, we know that there is no really cure for atrial fibrillation. And the comment on the late recurrences of atrial fibrillation after ablation also ties to this. Even though we may be able to suppress it and control it, we're really not curing the degenerative disease that is happening unless we have the appropriate interventions, or once we understand it better than when we understand it today. So risk factors for atrial fibrillation that have been well recognized include age, hypertension, heart failure, coronary artery disease, valvular heart disease, diabetes, obesity, alcohol abuse, thyroid disease, renal failure, and a chronic inflammatory process, among others, and among other markers or biochemical markers for atrial fibrillation. This is data from the ALPHA study. Is from the late 1990s. A group of 206 French cardiologists got together and decided to report each of them 6 patients with atrial fibrillation prospectively, and they followed them for 6 to 12 months. They ended with 729 patients, and they identified that 70% of those patients had some form of heart disease, mostly hypertensive heart disease, valvular heart disease, and other forms. Only about 29.3% of patients did not have associated heart disease. So we know there is a strong association between cardiovascular disease and atrial fibrillation. From the atherosclerosis risk in communities study, about 15,000 patients, a little less than 50,000 patients, there was a strong association again between hypertension, obesity with a BMI of more or equal to 25 kilos per meter square, smoking, diabetes, and cardiac disease with atrial fibrillation. We already saw some of these. The pathophysiology of atrial fibrillation involves some genetic predisposition with different degrees of mix with environmental factors and personal factors leading to heart disease or heart disease equivalents like diabetes. That leads to inflammation and fibrosis, mostly in the left atrium, with different degrees or no degree of left atrial dilatation, but certainly some electrical and sometimes mechanical remodeling that is added to autonomic imbalance, humoral factors like the renin angiotensive aldosterone system activation, and eventually creates in the atrium the substrate for slow conduction, abnormal automaticity, and trigger activity all together in different degrees, leading to a combination of triggers and substrates that put together lead to the clinical syndrome of atrial fibrillation. That's the way we understand it today from the pathophysiological standpoint. So another question for the audience. So beyond the stroke prevention, which is paramount in atrial fibrillation, and the strategies of rate and rhythm control, which should also go together, what do you recommend for your patients with AFib? One, weight loss, exercise, and diet, alcohol avoidance, screening for obstructive sleep apnea, all of the above, or honestly, by the time I'm done explaining them their medicines and why they need to be on anticoagulation, I have no time for this. And I have to confess, I find myself mostly on that 5 category. So there is no shame on saying you don't have time, because it takes 2 patient visits slots to convince them they need to be on anticoagulation. All right, so we're giving the right recommendations, and there is a lot of data to support that. And I'm glad you can find time to do it, because it's not easy, right? So the modifiable risk factors we're going to discuss include obesity, alcohol intake, sleep apnea, lack of exercise, smoking, and some touch on diet. From the Framingham Heart Study, from the Women's Health Study, from very large cohorts like the atherosclerosis risk in communities, as we saw, it is very clear that obesity is associated with the higher risk of atrial fibrillation. It's a very strong statistical association. Now, with the legacy trial that Dr. Lack already mentioned, we got some data showing that if you really engage patients in a very intense weight reduction strategy and you achieve sustainable weight loss, there is a significant reduction on the incidence and recurrence of atrial fibrillation, and the arrhythmia-free survival is significantly higher on patients who lose more than 10% of their body weight during the process than the patients that lose 3% or less of their body weight. That's statistically significant. It represents 46% survival free at 5 years for patients who are able to achieve in an intensive weight reduction program more than 10% reduction of the body weight. This graph is only including patients who did not undergo ablation or antiarrhythmic drug therapy, which is a subset of the legacy trial. In these graphs, all the patients are included. You can see that the arrhythmia-free survival is even higher for those patients who could show a linear loss weight, which means weight loss with less than 1% gain in the process. So a consistent weight loss in over time. In the right, you can see the survival is also, the arrhythmia-free survival is also higher for those patients who have less than 2% weight fluctuation. So being able to lose 10% of your body weight and keeping that weight down and not having fluctuations is predictive for a reduction of recurrence of atrial fibrillation. And again, in these graphs now are included all the patients who had antiarrhythmic drug therapy, no antiarrhythmic drug therapy, ablation, and no ablation. As a proof of concept, this is not really a lifestyle modification, but you wonder, is it the weight or is it the process of losing the weight? So with bariatric surgery, these are 4,000 patients in a prospective registry of patients who underwent bariatric surgery. There was close to 20% reduction in the incidence of atrial fibrillation. These are patients who did not have atrial fibrillation and had a bariatric surgery, and over 20 years follow-up, there is a sustained decrease in the incidence of atrial fibrillation among those patients. So weight loss has a significant impact. And you could argue patients who go through bariatric surgery probably engage in lifestyle modifications as well, but this is a prospective registry that did not control for that. So having had weight loss or having had a bariatric surgery that leads to weight loss reduces your incidence of atrial fibrillation, your risk of AFib. Now, the negative effects, there is no doubt on weight loss and reduction of the recurrence and incidence of atrial fibrillation as both primary and secondary prevention. Now, moving to alcohol. So, do you believe that the negative effects of alcohol in the myocardium offset the benefits of low or mild alcohol intake, regular alcohol intake of 1 drink or less a day, and outweighs the benefit on the lipid profile, because we know that there is a benefit. Raises HDL has been attributed to the explanation of the French paradox, right? Saturated fats and increase in HDL and cardioprotection. So yes, it offsets it. No, we don't know, or there are more relevant therapeutic targets than alcohol, and I really don't want to engage now on a discussion about alcohol with my patients. So when we're getting towards the end, I'm going to confess that I don't think I know the answer. I don't think we know, right? So, well, we're all mixed, you know. It does seem that if we talked about patients with atrial fibrillation, probably the answer is yes, they shouldn't be drinking. You know, we should prevent atrial fibrillation. If they don't have it as a primary prevention, I don't know that we know for sure, you know, about the cardiovascular benefits and, you know, the regular alcohol intake. But we do know that alcohol has a toxic effect on the myocardium, especially in the atrium, and alcohol intoxication leads what has been recognized for many years and first reported in 1978 as a holiday heart syndrome. So we know about it, but now this is a very powerful study. It's a very large, it's a combination of a meta-analysis and a 2-cohort population studies from Sweden, in which just the 2004 combination of cohorts added 79,000 patients. And to that, we had the meta-analysis of all the other studies. And what is represented here is the relative risk and the odds ratio or the risk ratio of atrial fibrillation per 1 drink a day increments. So you can imagine if you do 2, 3, 4 drinks a day, of course, this is in a linear progression. So there is definitely, with a small amounts of alcohol consumption, there is added risk to the development of atrial fibrillation. Alcohol is known to cause atrial inflammation and oxidative stress. That's what we understand as a mechanism, as a pathophysiological mechanism for alcohol in atrial fibrillation. But we also know that it increases blood pressure. It has an increased incidence of obstructive sleep apnea, and of course, at a higher amount of alcohol can lead to LV remodeling, left ventricular hypertrophy, and cardiomyopathy or alcohol cardiomyopathy. So if we plot some data that we have for cardiovascular risk reduction and alcohol, it seems in red that moderate amount of alcohol does provide some protection. But when you see the blue line, that's your projected incidence of atrial fibrillation with alcohol intake, and it's linear and progressive. So patients with atrial fibrillation should be restricted from drinking, because there is a definite association even as small amounts of alcohol. Now, exercise presents a very interesting phenomenon. This is for more than 20,000 patients in Norway that were followed prospectively, and patients were classified as having low, moderate, high, or vigorous levels of physical activity by questionnaires that had been validated. This is survey data from these cohorts. And if you engage into moderate physical activity, which was 4 hours a week of exercising for pleasure or biking, without necessarily having recreational sports or competitive sports or aggressive training, which could be vigorous, you have about 20%, like 19% risk reduction on the incidence of atrial fibrillation. This is follow-up over also a very long period of time, like 20 years. If you do engage into higher intensity exercise and physical activity, you offset the benefit of that was seen with moderate intensity of physical activity. And if you engage into vigorous activity, then also the resting heart rate drops, and that was correlated with a trend, not statistically significant, but a trend towards higher incidence of atrial fibrillation. So there are benefits with exercise, but we probably have to engage into a prescription pattern that classifies what kind of exercise and what intensity patients need to do. Now, patients, that was primary prevention. Those were just populations exercising and their incidence of atrial fibrillation. When you look at patients who have been diagnosed with atrial fibrillation and it's non-permanent atrial fibrillation, this is a small group of patients, 51 patients, that were engaged into aerobic training for 12 weeks. And you can see that towards the beginning of the training, in the 1 to 4 weeks, there may have been a trend towards higher burden of atrial fibrillation, but by past 12 weeks, there is close to 50% reduction in the burden of atrial fibrillation. And this is very reliable data, I like to believe, because this was done. These patients were followed with implantable loop recorders, so they knew the time they were in atrial fibrillation, and this is counted time spent in atrial fibrillation. So patients with AFib and symptomatic AFib should also be recommended to exercise regularly, aerobic exercise of moderate intensity. Smoking, as we saw before, is also associated with risk of atrial fibrillation. Here from the atherosclerosis risk in communities again, this is data that shows a duplication of the risk of atrial fibrillation in current smokers. Ever smokers, people who even quit smoking, still have risk, but less than if they are smoking actively. This has been also shown in other large cohort studies with a different degree of association, but statistically significant. For the Women's Health study, the hazard ratio was 1.2, and for the CHART-AFib, which was a larger compilation of population studies that included the atherosclerosis risk in the communities, it was a 1.4. Statistically significant. When we talk about obstructive sleep apnea, these are a comparison between patients with atrial fibrillation going for cardioversion and general cardiology patients that were used as controls. And you can see that the prevalence of obstructive sleep apnea among patients with atrial fibrillation is very high, is close to 50%, probably 48%. And there is a strong association between atrial fibrillation and sleep apnea. Now, when those patients undergo cardioversion, this is a different cohort of patients. This is even a smaller group. It's like 39 patients compared to 70 controls. 39 patients with a sleep apnea that underwent cardioversion. Those who were treated, you can see it at the right side, untreated for obstructive sleep apnea with a CPAP, had a higher recurrence rate at 12 months than those patients who were treated with a CPAP for their obstructive sleep apnea, which actually the recurrence rate was very similar to the controls. So treatment of obstructive sleep apnea doesn't necessarily eliminate the recurrence of atrial fibrillation, and we have experienced that clinically over and over, but decreases the recurrence and the burden of atrial fibrillation and brings it back to the point or to the level of patients who don't have a sleep apnea. The same happens with ablation. Patients treated, this is from Brigham, data on about 151 patients that underwent catheter ablation and had a diagnosis of a sleep apnea. So patients who were treated, their recurrence rate at a few years is still about the same that patients who didn't have a sleep apnea. All the patients with a sleep apnea, of course, have higher recurrence rate after pulmonary vein isolation for the treatment of atrial fibrillation, and the highest occurrence of atrial fibrillation episodes after ablation was on those patients who were not treated for sleep apnea. So all this discussion leads us to the REST-AF trial, which is kind of the study that put together all the comprehensive risk factor modification. It's probably the more comprehensive study that I'm aware is available, published. These were patients who went for atrial fibrillation ablation, and they had the option of engaging. It's about 149 patients, and they had the option of engaging into a very aggressive risk factor modification or not. So a little less than half of them, some like 66 patients, decided to go for the very aggressive risk factor modification, and that included treatment of hypertension, treatment of glycemic control, diabetes, treatment of lipid profile, weight reduction, exercise, moderate exercise activity, smoking and alcohol cessation. And you can see that arrhythmia-free survival after ablation is definitely higher there in the red line. Compared with 1 and 2 and multiple procedures, is higher on patients who engage into a very aggressive risk factor modification strategy, which includes, again, alcohol cessation, smoking cessation, and it was a voluntary decision for the patient to engage into that. So this gives us I think, solid ground to promote lifestyle modifications and risk factor management on patients who have atrial fibrillation before or after catheter ablation, although that data was from after catheter ablation. And I would say it probably is an argument to justify atrial fibrillation as a qualifying diagnosis for cardiac rehab, which today, I don't know if in other states is, but I think it's most of the U.S. is not accepted, as a diagnosis for cardiac rehab. So talking about diet, there is a lot of conflicting data on diet, and most of the big intervention studies have not shown benefit. But this is the one piece of data that shows something that is promising. This is from the prevention with Mediterranean diet study done in Spain, 6,000 patients that engaged into a control diet, which was basically the recommendation of low-fat diet, or they were randomized, right? So either the control diet or the Mediterranean diet with an extra component of nuts, or a Mediterranean diet with an extra supplementation of extra virgin oil. And there was, as you can see there in green, a significant reduction on the incidence over time of atrial fibrillation with extra virgin oil as a supplement to a Mediterranean diet. So this is kind of the one dietary intervention that seems to have very clear beneficial effect. That is available. Of course, not enough probably to make a recommendation, but very thought-provoking. When we talked about fish oil, we are aware of small studies showing benefits of fish oil supplementation for prevention of atrial fibrillation after surgery. Unfortunately, that didn't come out to be effective in larger studies down the road. We know that populations who have high consumption of omega-3 polyunsaturated fatty acids are less likely to have atrial fibrillation, but that hasn't been able to be replicated with supplementation of purified supplements. So there is no recommendation at present to use it for that reason in the prevention of atrial fibrillation. So any intervention that modifies your risk for hypertension, diabetes, and heart disease is certainly going to decrease your risk of atrial fibrillation. Now, there are other things that have been, despite popular belief, caffeine, for example, has no data on, and actually the data that is there is null. There is no increased incidence of atrial fibrillation or recurrence of AFib on patients who drink caffeine. For cannabis, there is only case reports, so it makes sense that there may be something, but maybe now that it's being legalized, we're going to have more data, and we're going to know if cannabis is associated with atrial fibrillation or not in larger groups of patients. But for now, there is not. Reduction of stress, anxiety, and depression. There is not a lot of data. Actually, from the Women's Health Study, the data is that there is no increased risk in women for psychological stress and anxiety for atrial fibrillation. But there are other studies, older, showing that type A personality, propensity to anger, and aggressive behavior in men is associated with higher risk of atrial fibrillation. What is certain is that psychological stress, depression, and anxiety probably prevents patients from engaging into healthy lifestyles. And that is probably a target for intervention, but we don't have a lot of data on that. So now I have a couple of more questions. Are you ready to recommend? Well, you were already recommending lifestyle modifications in the first question we had. So I guess let's see if we go higher than 80% this time. So yes, we're ready to implement lifestyle modifications in patients with AFib. No, I need more data. Only after ablation and left atrial ablation exclusion. I'm sorry, Dr. Leck already left because that was tied up to his talk. I need an extender, health coach, or nutritionist to help me with that, or I will see you in ACC 2018 and I will tell you then.
Good promotion.
There we go. We went up to 93%. Wow. That's good. So very good for 25 minutes. So I have 50 more seconds. This is kind of a personal question. Have you identified any patient with dietary triggers for their atrial fibrillation? We know about case reports of cold drinks and hot drinks triggering either SVT or AFib, spicy foods or heavy meals, gluten, others or none. And while you're answering, I'll tell you why. I have identified, like in 15 years, maybe a series of 6 patients or so that do have dietary triggers, and they come back and say, oh, I stopped doing that and I haven't had episodes. I don't know if it's sustainable. I don't know if it makes sense, but as we were saying before, as long as patients feel better, I buy it. All right. Well, in conclusion, prevention of heart disease prevents atrial fibrillation. I think we knew that already. Weight loss, alcohol avoidance, moderate exercise, smoking cessation, and treatment of sleep apnea reduces the risk of atrial fibrillation. Treatment of atrial fibrillation should include risk factor modification routinely, and more data is still needed for specific dietary recommendations beyond weight loss. Thank you.
Thank you. That was very informative. Those were some great references you showed. Are there any questions? I'll start with, we have many audience response system questions. I'll try to pick some that I think would be relevant to the topics you just discussed. One is a modifiable risk factor, if it's modified, such as weight loss, in a patient with AFib and converts to sinus rhythm, do you still need to continue anticoagulation?
Yeah, I think that we don't know yet what's going to happen a few years down the road. So, you know, as a concept and based on most of, the data that was shown after ablation and the data we know from antiarrhythmic drugs, unfortunately, even though we're modifying risk factors to decreasing the burden of atrial fibrillation, we don't know that the patient is arrhythmia-free. So my quick answer is no. If the patient has been arrhythmia-free for a long time, I can tell you, I confess, they're going to convince me that they're going to stop it, so I may consider using a loop recorder and allow them to stop the anticoagulant. And the reason I'm using a loop recorder is because it's going to give me an instrument to go back and tell them, listen, you needed to stay on it, because I think sooner or later we're going to find AFib again. So I don't think we have enough resolution of AFib to get to stop anticoagulation at any point. We can negotiate how to manage that risk and follow them. The other concept is that patients that are CHA2DS2 or 3 are probably at high risk of a stroke regardless of the atrial fibrillation, so they may benefit from anticoagulation even if they didn't have AFib.
I suppose if someone lost weight, that might reduce their AFib burden, which wouldn't impact your advice on anticoagulation, which is largely based on risk factors for stroke. But theoretically, someone could lose weight and no longer have hypertension and diabetes and have a CHA2DS2 score of 0. Would that impact your decision?
Probably, yes. I do believe in, like tachycardia-induced cardiomyopathy. I don't know that we have data about it, but if tachycardia-induced cardiomyopathy, when it resolves after you control sinus rhythm, I don't think they have heart failure anymore, so I could take it away from their CHA2DS2 score. So I guess the answer is yes. If their CHA2DS2 score gets to 0, again, it's controversial. Anticoagulation still reduces the risk of a stroke, but then there is the risk of long-term anticoagulation versus the small gain with anticoagulation for a stroke reduction. So I would say probably yes.
You talked a little bit about the use of implantable loop recorders in patients with AFib. There's another question about how you would use things such as the AliveCor app. Can you talk about that?
Yes, well, I do. I'm a strong believer on patient-driven data and kind of management of their condition. So I do recommend the AliveCor when patients don't want an implantable loop recorder, or if they really have very symptomatic, sporadic episodes. And I wouldn't use the AliveCor to make a decision on anticoagulation, but I could use the AliveCor to make a decision on management. Are they rate controlled when they have a recurrence? Are they really having AFib versus PACs? Because we all know that there is a lot of subclinical atrial fibrillation, so we cannot rely on a device that they are actively engaging with, driven by symptoms, for making the diagnosis of recurrence of AFib. But for management of their symptoms, for the peace of mind, many patients come and call and they are asked to go to the emergency room just because they had AFib. Having the AliveCor in their hand and knowing that they can transmit the episode to us and next day in clinic we'll manage them, gives them the safety of not going back to the ER and knowing that someone is watching. So I think for peace of mind, to knowing what's happening, what is it they're feeling, I use it. Not to make a decision on anticoagulation.
Why would you not trust the AliveCor to make a decision about anticoagulation?
Oh, because if the patient does not, the question is why not to trust the AliveCor to make the decision on anticoagulation. I do if I see AFib, but if I don't see AFib, I don't know that they don't have it. Because of the subclinical AFib that happens at night, that we have seen on the ASSERT trial for pacemaker patients. There is, the AliveCor is good to know that the symptoms are something, but I don't know that they're good to know if the patient has or not AFib. The loop recorder is continuous. It's a loop.
It's a great way to correlate symptoms with their rhythm. How many people here have used an AliveCor or prescribed it? There's still a minority of people in the room. I would strongly recommend it. I have no conflict of interest on this. Patients that don't have symptoms every day that a Holter's not going to capture, or don't have symptoms every 30 days that an event monitor is not going to capture. And AliveCore is an app for the phone that allows you to record a single lead rhythm strip. Sometimes the challenge is how to transmit that information. I recommend to patients that they print it out or bring their phone with them when they come to clinic. There's this tendency to want to email these things, and it can become a big burden. But I think if you manage it the way you do patients who check their blood pressure and vital signs at home and bring them into clinic, it doesn't add a lot more, and to the work, and it can add a lot to the care of the patients who may not have ever had AFib diagnosed before until they use these apps. It's available online. You don't require a prescription anymore, and it costs about $90.
Yeah, I think it gives the patient a sense of control that is priceless and saves you a lot of time in clinic.
All right, we'll stop there. Thank you very much. That's great.